Good evening, everyone, and welcome to the Med School Tutors Question Strategies for Step 2 CK. I am here with Dr. Michael Trainer. Before we jump into things, just wanted to introduce ourselves briefly. My name is Moses. I'm an intern in internal medicine and have been with Med School Tutors for a number of years now, helping folks in their standardized testing. Michael, tell the group a little bit about yourself.
Yeah, just like Moses, also an intern out in California, went to med school in Georgia, intern in neurology. Also moving through my internal medicine years, been with MST for probably about 3 years now.
And if we're lucky, we'll convert him from neurology into internal medicine. I don't have high hopes for that, though. So what we have lined up for you tonight is really going through systematically some tips and tricks for how to tackle Step 2 CK questions. We'll compare and contrast with Step 1. We'll go over some common question themes. If you've taken other types of this exam, some of the themes will be similar, but there are some key differences that we will go over. We'll give you specific strategies around tips, both in terms of the resources that you can use to maximize your study time, and also go over some questions and highlight how we might approach questions in an efficient way with some examples. And along the way, we want this to be as interactive as possible. So please use the chat function, send us questions. We'll have a live Q&A session at the end, and we'll get to as many questions as we can. Michael will be monitoring the chat throughout, and we'll try to get to as much as we can. But obviously, every student is different, and if we don't get to your question, the contact information is below, and we would love to hear from you, really with any question that you might have that comes up through this webinar. And just to give you a bit of a sense of who we are, where we're coming from, Med School Tutors is a service that provides online tutoring really along the pipeline into becoming a physician from pre-med through residency. We've worked with a lot of students and really bring a wealth and diversity of experiences and backgrounds. We have residents, interns like Michael and myself, but really med students who've really crushed the boards, attendings who've seen the full spectrum, and we're all, well, maybe I'll speak for myself, but we're nerds who really enjoy this material and also enjoy the community aspect, which, you know, given everything that's going on, sometimes that's missing, and having someone else to talk through concepts in medicine can be a big help. And of course, we have Maisie, the MST pup here on the screen, which just warms my heart every time I see her. So Michael, take us away. Step 1, part 2.
Yeah, so I think this is kind of like the big question is, hey, what do I do differently? What's the same? How do I approach this? I feel like I've done this before, but it also feels like a whole new process and I'm in a different environment. So we'll start with the things that make it similar in that you don't get to forget the basic pathophysiology of the disease you've been covering. And that's actually a nice thing. I don't want you to look at this test and be like, oh man, it's this whole new bucket of information that I have to learn. Heart failure is still the exact same heart failure that you learned previously. You're just going to have to think about it and approach it in a different way. And you need to retain some of those core basic pathophys principles that you learned for step 1 in your core coursework. Again, very similarly, you need to have the labs, the images, the physical exam findings to make a diagnosis. And then you might have to go a step or two further. So it might not just be like, hey, do you understand that this clinical syndrome is this disease? What is the most likely side effect of the most common medicine to treat this disease? So you have to use the vignette to diagnose. You then have to know which drug might treat that condition. And then you actually might have to know the toxicity of the drug. So that would be 3 orders of a diagnosis, a medicine, and then the 3rd order being the side effect. Things that remain similar, UWorld is going to be the cornerstone of your study plan. I want you to kind of really ingrain in your mind, and it's something that I commonly go over with students. UWorld is a learning tool. It is not an assessment tool. I'm happy, but it's not the marker when you come into a tutoring session and you say, oh, I'm getting 90% of my UWorld questions right. And I'm like, that's great. But are you learning from the things that you don't get right? Or are you picking up extra information from the beautifully outlined charts and explanations. So get it through that. UWorld is an awesome learning tool for you. And then we'll talk about some other things that you can use to assess yourself, like the NBME practice exams. So again, much like step one, there are forms that you can take. There are shelf practice exams. You can kind of target areas that you might need more than others. You can take an extra OB-GYN shelf, or you can do a full step 2 NBME form. The same test writers for step 1 and step 2. So the format in which you're going to be approaching an NBME style question is not going to be wildly different. Sort of a difference. We mentioned that your environment is a little different now than when you were studying in your preclinical clerkships. So there are going to be some rotations where your on-the-job learning is going to correlate so beautifully with what you're going to be tested on. You're going to be on the ward. You're going to have a patient who has a bump in their creatinine, and your attending is going to ask you what you would like to do to work up their AKI, determine if it's pre-renal, determine if it's post-renal or obstructive. That is going to match beautifully with what you go and then later learn to approach a step 1 question about AKI. I'm sorry, step 2 question about AKI. And then there are going to be some rotations where your on-the-job learning might feel a little discordant from what you're going to need to go to do to be successful. So some examples being like a lot of acute surgical management, being operations of procedures and things like that. And then sometimes in the surgical questions, it's more, well, would you XLAP this person or not? Does this person need imaging before surgery or not? Things that aren't driven home as hard on the rotation. But the more you pay attention to where those things differ, the more I think you'll see that there is actually a huge commonality between what you're doing on the wards and what you need to study. And unfortunately, the other thing that stays the same is that it can be a little frustrating. It's always hard to be reminded of how much we don't know. And that absolutely can wear you down with some time, but you have people like Moses to help walk you through and teach you some stuff.
Amazing. I agree with all of that. And really what we have here is the compare and contrast in a slightly different format. A lot of what Michael has gone through. We've talked about how the resources for Step 2 CK can feel broader, and the consensus is not as strong as far as what is the Bible, the gold standard. But the good news is that there are many resources that you can use that might match your particular learning style a little bit better. And of course, there are numerous paths to Step 2 CK, especially now with the restructuring of curriculums. And so I don't want to assume that everyone on the call has taken Step 1, but do want to draw some of these comparisons. Again, more big picture, more pathophysiology, and frankly, more in line with what you are actually going to end up doing as a physician on Step 2 CK as compared to the nitty-gritty of Step 1. Another big difference is the amount of time that you have or that you even need to be successful with these exams. For Step 1, there is definitely a range of times that folks take to study for it, but typically, on average, it is longer than the time that is given for Step 2 CK. And so that also changes the structure of your study time and the number of resources that you're able to effectively get through during a Step 2 CK study period. And I also want to recognize that all of this is wearying. Michael talked about how it's the same learning process and the joys of learning, but also some of the frustrations around learning. And this really brings me to something that I find so important to emphasize when I'm working with students, which is that being very diligent about your sleep, about your exercise, about your human connection with others, staying rooted in why you're going through this in the first place is really important, because when you're facing a question bank that, with thousands of questions, you need to find that reason to get up in the morning. And I think it's underrated how important that motivation and keeping burnout at bay really is. A lot of the questions, again, are second and third order. And, we've already talked about that a little bit. And connected to the fact that the timeline can be a little bit different, you likely won't have multiple passes through the material. And so really being efficient and tapping into how you learn best the first time around so that you really extract as much learning and as much sort of test-taking skills as you can during that first pass through the material will be really critical so that when you get to game day, like ready to really tackle the exam and do well. And what we'll do in the rest of this webinar is to highlight some of the ways in which you can start doing that.
Great. So I know there was already a question in the chat, and this is absolutely like, I think one of the things that we need to think about moving into like step 2 world from a step 1 kind of mindset is how on earth do we approach like the next best step, right? So how am I supposed to know what the next best step? And then within that, there's actually several subsections of ways that we could be asked that. Do we want to diagnose this person formally, or do we want to treat this person empirically based on a clinical diagnosis? Do we want to manage this ourselves, or is this something that we automatically need to get someone from a specialty service involved in? Do we want to manage this with a medication, or is this something where we need to skip right on and do a procedural intervention to manage this? So the thing that I would encourage you to do to kind of deal with this like question, that's the kind of point number 1 in all the subsections, is when you're studying, pay attention to things that maybe you previously didn't have like a close eye to, right? So when you're reading about a condition, it says, oh, this is a clinical diagnosis, right? There's no formal imaging or laboratory values needed, right? So I think a good example would be hepatic encephalopathy, right? You don't have to have an elevated ammonia to prove that someone has hepatic encephalopathy. It's a clinical diagnosis of someone who has sleep disturbance, has potential asterixis on exam, right? Has exam and history findings that would make you worried about them having this. I don't have to do anything there. I should just go ahead and treat them, right? I should put them on lactulose. I should put them on rifaximin. Whatever that scenario might be, I know it's clinical versus something else where I may actually need to formally diagnose, right? I may need to have imaging to prove it. I may need to have a laboratory marker to prove it. I think, for example, like rheumatologic conditions come to mind, right? Where I have to have the perfect array of a positive ANA and a positive rheumatoid factor and a CCP and all of these things to be like, yes, I feel comfortable making this diagnosis, then I will recommend treatment for this person. So pay attention when you're studying, you know you're going to be asked about that. Focus on it, right? So I talk to students a lot about putting a stop sign up when things you're previously reading and might gloss over. This is a great time to put a stop sign up, right? Clinical diagnosis or not is super helpful to add to your bank of diseases. That helps you with the management or referral, right? If this is something that you have read as a clinical diagnosis and that you know that there's then a treatment for, you probably don't have to refer this person out of the gate. If the question stem makes a kind of a point of telling you that you've tried the typical things, you've done the first line, and it feels like you've gone as far as what you've studied has told you in your head, maybe it's time to pull someone in with a little more experience. So these have great corollaries to actually the way that you're going to approach patients in real life. So someone comes in with a new diagnosis. As a general internal medicine resident right now, I feel very comfortable taking their work up to X point. I get to X point, things are still confusing. Great, I need to escalate further. I need to pull in someone who has the experience to go a little further. And then medication or surgery or procedure, I think falls in with all of the rest that I've said. Okay, the next point I want to spend a little more time on as well, which is the best diagnostic tool. So sometimes you need to think in terms of cost, right? If there's two things that are equal, I might leverage costs or maybe harm potentially introduced to the patient, right? So if it's an invasive procedure in a child, right, I might not want to do repeated lumbar punctures in a child to drain fluid, right? I might elect for something different. So use kind of what might be like your gestalt from what you see in the real world to bring to this. The example that I also love to give to students here is pay really, really close attention. I know Moses is going to talk about this too, to exactly what the question is asking. If I have a very delightful 75-year-old lady that comes to clinic, she's getting lost driving around her neighborhood, she's unable to manage her finances, her family's concerned because she leaves the oven on sometimes, she's forgetting the names of close friends, I'm pretty sure I have a good diagnosis in my head. And then it asks me what's the next best step in her management. That would be neuropsychiatric testing, right? I want to formally diagnose this person with Alzheimer's disease. I want to evaluate their cognitive status. If they ask me the gold standard in diagnosis for this patient, can anyone in the chat remind me what the gold standard of diagnosis for Alzheimer's disease is? So biopsy, and I'll take it a little further, it's actually like an autopsy examination of the brain. So the gold standard is different than what my next best step in management would be, right? So never in my wildest dreams would I recommend an autopsy to diagnose. But if the question asked me what the gold standard was, that's my answer. So being really hyper-focused on what exactly the question wants from you, and then what makes sense in your mind, right? Do you need imaging? No. Someone commented in here that it's more or less a clinical diagnosis. Absolutely, right? So how do you leverage all of those things when you're approaching that? We'll talk about things that are the most likely diagnosis, right? So that sometimes helps you to maybe study epidemiology a little more than maybe you focused on previously. I also think it helps you in the hospital, right? You see 20 cases of pancreatitis between your surgery rotation and your internal medicine rotation, and 10 of them were caused by a gallstone, and 10 of them were caused by someone having alcohol use disorder. You then go take a test and it's asking you what's the most likely etiology. It's going to be one of those two, right? The prevalence that you have in real life is usually going to match testing prevalence. It's not going to be a scorpion sting. Most likely complication of conditions, right? I think matches really nicely to a textbook. I know people are asking, like, how do I get this information? Where do I pull it from? These next ones match really, really nicely with the resources you're going to be using. Things like the books we'll go over, question banks, like these are the most likely complications, the most likely risk factors. And then again, stay curious and connected to the basic science, right? It's cool to know what the disease is and why it's happening.
I love all of that, and I can't emphasize how much um, having an understanding of how does one arrive at a diagnosis color and just exponentially expands your ability to answer these questions. You know, Michael, you brought up pancreatitis briefly. Um, Knowing that you can make that diagnosis with 2 out of 3 criteria, right? Where is the physical exam consistent with a picture of acute pancreatitis? Are there serum biomarkers in the form of lipase or amylase meeting the thresholds that one would need to make that diagnosis? And then do you have imaging findings that support a diagnosis of acute pancreatitis? You know, the way the vignettes are structured, they're not going to say, and here are the 3 criteria, 1, 2, 3. They're going to be sprinkled in with other details, you know, the social history, the family history, all excellent things, and we learn that are important for working with patients. But your job as the test taker is to cut through that supporting structure and hone in on the fact that this person has now met 2 or 3 out of 3 criteria, necessitating or explaining what your next step might be. And then the epidemiology is also excellent. In the chat, can folks put the 1 or 2 most common etiologies or precipitating diseases that lead to acute pancreatitis? And Michael, I'm going to rely on you to look at the chat and see what folks are saying.
Yeah. Gallstones. I see alcohol. I see hypertriglyceridemia, Jay, which is a great answer. That is a factor for pancreatitis. But let's say that I just gave you a person comes into the emergency room with epigastric abdominal pain that's worse when leaning backwards, associated with nausea, non-bilious vomiting, right, and an amylase of 400, right, and a lipase of 400. And then they gave you nothing else. They gave you no risk factors. They didn't tell you that their father had an MI at 30 years old. They gave you no other information. This actually might be something where people are like, oh, it's too vague. How am I supposed to know the answer? You actually got to go on epidemiology, right? So this 30-year-old, you know what I mean, man, I would probably lean towards alcohol use disorder. Unfortunately, in the way that we tend to kind of throw bias in the way questions are written, like female, and they tell you that she's multiparous and has a BMI of 28, like that would make gallstones probably a little higher. So in general, use epidemiology to help you be like, which of these things in a list makes the most sense? Jay, I would put hypertriglyceridemia, like, I don't know, 3 or 4 down. It also has to be over 1,000 usually to cause, which is crazy high and usually associated with some sort of familial disorder. But good answer.
And that's exactly right. What Michael just illustrated was the clinical reasoning really around the vignette. It's the story of the person, and then it's also knowing the criteria and the epidemiology. All of that comes together to inform your answer, so that there really is one clearly defined best answer, and it's depending on the factors, either alcohol use disorder or you know, stones in the biliary tree. And so all of this can really be boiled down to use what you know. And I think you all should give yourselves credit. You've gone through a lot of medical school. You've put in a ton of hours. Um, you're ready to take this exam. It's a matter of really applying what you know to the vignettes and being efficient in your approach to them, which we'll also sort of model a little bit later. I would also encourage, if you are in the position of facing your Step 2 CK study period and it hasn't quite started yet, some introspection I think can be useful. And thinking about, okay, I've taken standardized exams before, more than likely. What worked about every step of that process for you? What types of resources work for you? Are you a video person? You really absorb it that way? Are you more of an audio person? And there are podcasts out there that probably aren't geared specifically towards Step 2 CK, but can be helpful. Are you a very tactile person? You like writing things out? And how do you work that into your study schedule? And then thinking about what didn't work. All of us have had a day or a couple of days where we feel like we put in a lot of hours and didn't extract a lot of benefit from them. Learn from those experiences. It happens to all of us. And having that growth mindset that it isn't that you're a bad test taker or I'm a bad test taker, but it's more about continually improving our process. Some of the tips that I've got that we've already mentioned actually is start with a question being asked. And I know that sounds really, really obvious, but it's critical to have a clear understanding of what it is that you're looking for. And this is very important. Now, I'll try to highlight it when I do my sample question, but not only is that important so that you don't make a mistake in picking an answer that's like correct if the question was worded slightly differently, but it also informs how I'm reading the vignette. If I see at the very end that it's a diagnosis question, my mind is primed from the get-go. Okay, is this person a child, an adult, or an elderly person? What diseases are common in those age groups? Next, what are their comorbidities, or what other factors from their family history, from their social history, raises or lowers their risk for any of a variety of disorders? If someone comes in and they says, I've really struggled with smoking and a BMI of 31, just at baseline, my suspicion for cardiovascular disease skyrockets. Now, that doesn't mean it's the final answer, but I'm calibrating after each sentence. I'm calibrating I'm building almost like a mental model of this person in my head and thinking, what are the things that are likely to be medical problems for them? Some other really concrete tips is highlighting can be a bane and a curse, honestly. Some folks find that they highlight everything, and highlighting everything can sometimes be the same as highlighting nothing. Being strategic with how you highlight. And this ties into rereading. Ideally, you would go through the vignette, highlight the relevant portions, maybe go back to those highlighted portions, but entering into these cycles of reading and rereading can be dangerous from a time management standpoint, and developing good habits around all of this can be very helpful, which leads to the next point. You want to get to the point where you're practicing under timed conditions that are similar to the exam that you're going to be taking. And this is of particular importance in a couple of scenarios. I've worked with many, many students, some of which previously had accommodations for various reasons and have gotten extra time. And for whatever reason, those accommodations are not available to them for some of these exams. If you're in that position, I would encourage really trying to get to the point where you're practicing under time conditions. But frankly, it's something that I recommend pretty much for all students as quickly as possible. And I've already said a lot about wellness. I don't think it can be said enough. Making sure that you're coming at this from a place of being centered, of being healthy is really, really important. I can speak as an intern now. This is not just true about Step 2 CK. It's true about really every step in medical training. And now is not too early to really prioritize this for yourself, generate concrete plans on how you're going to maintain your wellness, because it's really critical. Michael, do you have any other tips that aren't on the screen right now that you found useful when you've worked with students?
Yeah, you highlighted the most important thing, I think, and it's harder to say without the amazing background that you just gave earlier. A fundamental difference between step 1 and step 2 is on step 1, it's a 32-year-old woman comes in with eye pain. And you're great, question over, she has MS, next. that is, you can kind of get away with it a lot of the time in a diagnosis question. On step 2, you're going to get like a 70-year-old who comes in with shortness of breath, right? And they have a history of heart failure, and they have a history of COPD, and they've recently had a GI bleed. And at the end is like, what's the most likely cause of this patient's shortness of breath? And you have to read the entire question and basically in your mind say, this gives points to a cardiac cause. This gives points to a pulmonary cause. This takes away points from a pulmonary cause. It's not going to be neatly packed in a bow for you to diagnose this person. You're going to actually have to use a lot more of the information from the vignette, and you're going to have to play a little bit of a tug of war sometimes. So that's a huge difference. And Moses did an awesome job, like, preparing all of you for that.
Oh, thank you so much. That point is so critical because it's moving from a buzzword driven process to almost like a Bayesian, and I don't want to get too nerdy here, but almost like a Bayesian approach is what you were just describing. And I'll add an extra just tip for free here, and that is often the absence of evidence is really, really telling. You know, if you tell me that there's a patient coming in, let's say that same patient, older, both CHF and COPD.
They have no JVD and they have no S3.
Bingo. Yes, that's exactly right. If you don't have evidence of volume overload, it's going to be really tough to convince me that you know the shortness of breath is really being driven by pulmonary edema. So keeping an eye for if this was the answer, what would I expect to see in this vignette? And if you don't see it, warning bells should be going off. Should I be entertaining an alternative hypothesis more strongly? And I'm a clinical reasoning nerd at heart, so this just makes me so happy.
Thanks, Sam. All right, so there's a couple of questions in the chat, just to like answer them aloud, which also I think bridges really nicely into this next. So how do we know all this material, right? So like Moses and Michael, you guys are talking about like strategy, like great, I have this differential in my head for shortness of breath. You guys mentioned a bunch of diseases and you're telling me to weigh between the two. How do I get that, right? How do I kind of load enough information in my hard drive so that when I'm faced with this scenario, I have legs to stand on? A lot of people are asking like, what's the key to step 2, things like that. I think having a great foundational fundamental knowledge, and some people are like, oh, well, if I didn't do well in step 1, like I don't have that. That's not true. Your fund of knowledge just might be a little different. And it might be really, really well served for this. So I think I just answered all the chat questions there. Moving into this next topic, which is like, how do we build that fund of knowledge? I mentioned it earlier. I do think that UWorld as a learning tool is and should always be the cornerstone. The idea of like saving UWorld for your dedicated to like see where you are. I typically will actually kind of strongly endorse that you do not do that. I think like saving it for an assessment is not using it to its full potential. So during rotations, right, engaging with UWorld, learning it, like loving UWorld for showing you how much there is left for you to learn, absolutely. I'm not a book-based person, right? But I think that of these 3 books, they tend to be like amazing comprehensive resources. I know we've mentioned medicine topics here. Medicine and surgery, if you look at the content breakdown, are between, it's medicine is like 50 to 60 and surgery is like 20 to 25. So at worst, medicine and surgery, which tend to have a lot of overlap, are 75% of your test. And then you have psych, which is also well covered in these resources, which is another 10%. So studying medicine is definitely the most bang for your buck. The Step Up to Medicine textbook is awesome, right? If you're using it for independent shelf exams, there is a neuro section, there is a family medicine section. I think that correlates really well in the ambulatory care section at the back of the book. Master the Boards, right? I think probably takes over a little bit from like our favorite First Aid for Step 1, like First Aid for Step 2, has absolutely like its benefits and does a pretty good job. I think that Moses and I probably see more people using these resources just being a little more thorough and a little more narrow in the medicine aspect, which is helpful. And then of course, like the American College of Physicians always does an awesome job with like free educational resources for med students, and their IM Essentials text and question bank are really helpful, right, for clerkship. Some of the questions tend to not be like USMLE style, but that doesn't mean they're not driving home super important points. Again, I'm so biased, but like, hey, how do you prophylax against a migraine versus how do you like acutely treat a migraine, right? So IM Essentials does an awesome job of like really laying that out, which one you do and when. Great. So that's what I have to say about your must-use resources. And Moses is going to now talk about some that were like, yes, absolutely, but in the right setting.
That's exactly right. I really, the point of this slide is almost the point of the first slide, which is you should be maximizing the utility out of your must-use resources, again, because the majority of this content, we know where it's coming from. It's coming from internal medicine, best specialty, what can I say? And, surgery and some other things. However, I remember when I was a clerkship student, I was leading up into Step 2 CK. And I'll be honest, psych was one of my first rotations, and while and surgery as well. There were things that I didn't feel as comfortable in, and this is where a little bit of self-knowledge goes a long way. What are the things that you really struggled with? Is it psych pharmacology? Is it some of that zone between surgical management and medical management? Often these go hand in hand collaboratively. And so on the screen, what you're seeing is a range of additional resources. And I won't go into the nitty gritty of every single one, just know that they represent a range of both text, of audio, of video. You have things like Anki, which some people love, some people really dislike. These should all be considered supplemental resources. And I would personally, and this is where style differences might come up. I would have a very low threshold to try something if you're feeling nervous in your heart. If your heart just sort of sinks into your stomach when you see a particular type of question, I would have a low threshold to explore a supplemental resource, with the caveat that I would also have a very low threshold to toss it if it's not working for you. And a second criteria for tossing it is if these resources are taking away from your ability to complete UWorld questions, to get through the question bank, those primary resources that we just went through, again, red flag, warning. You should definitely move on. I personally use Dr. Pestano's surgery notes. I thought they were wonderful. I'm
I
a
didn't
huge
use them at all.
Well, there you go. Exactly. Folks differ in what works for them. I'm a huge Anki fan, but really didn't use Sketchy Farm all that much, which is to say that I think sometimes there's this incredible pressure to feel like it's like Pokemon. I got to catch them all. I've got to have every single possible resource. I've got to have the stack of books that goes to the ceiling. And if I'm not using it all and I'm seeing my friends using some of these other resources, I'm missing out. I'm not going to do well. So I'm here to reassure you, no, stick to your fundamentals, have some self-knowledge, explore, feel free to do that, but also have a sense of your core trajectory and your core resources. And here I'll turn it over to Michael, actually. Are there any resources here on the screen that actually did work really well for you or that you recommend for students in particular circumstances?
Yeah, so I think that you highlighted like my favorite, and I started to like type it out just so it like was like auditory, and then like we also have the visual learners. You have our permission to fire something if you don't feel like it's successful for you, even if your friend is using it. So like Moses mentioned that I opened Dr. Pestano's surgery notes and I was like, wow, awesome. Like someone else is getting so much value out of this. That person is not me. I got value right from completing questions like that. I am a very question-centered learner. So it was like, can I complete UWorld to its entirety? Make a nice little notebook out of my UWorld notes, print that, draw additional pathways and diagrams all over the notes, and then that is how I study, right? So I tend to, and then if I watch something, let's say that I was like, great, I missed a question on evaluating a breast mass. Like, let me go watch the online med-ed on the back of my notes on the question that I missed, draw on the algorithm, circle it in red pen where I missed the algorithm. And then when I'm reviewing for the shelf, I then have a big red flag. Like, Michael, you've missed a question on evaluating a breast mass. You got to this point here where you thought that an FNA was the right choice, and it wasn't. You should have ultrasounded. So using, I think, really I tend to be very informed in the way that I look at my mistakes. And that's a habit that I built from college organic chemistry, right? I would draw out pathways, and as soon as I missed a methyl or a carbon, there would be a red smear all over that equation. I could never forget. It was like the scarlet letter that I've missed that. So I don't tend to have resource envy because I know this system works for me. I encourage you to find that kind of security in what works for you to help you retain information. So I didn't really answer your question, Moses, because I don't really have an answer for it.
Love it. You evaded that trap so skillfully.
Yep. All right. So moving on, right? So as I just kind of alluded that I do layer resources, right? So I am the type of person who will take notes on a UWorld question, have a nice UWorld journal. Med School Tutors has an awesome blog post about how to make a UWorld journal, right? So how do you remain connected to questions that you took 7 months ago, right? Where do you store them? How do you take notes on them? Hey, I took questions and it took me an hour to take the bank. How long should I review it? All of those are really nice. I think Moses and I each probably have our own way of doing it and our way of coaching students through it. There's a nice blog post on it on our site that I would encourage you to read for a starting place. So I mentioned that I print UWorld, and on the back, if I my notes on UWorld, and on the back I add extra things, right? So did I pick up from Sketchy Farm a while ago that this is the right drug for this reason, right? So or did I remember from online med ed that I need to think of this algorithm? However you can help put things together and make connections in your mind, the better, right? I think that when you're studying in GI and you are kind of talking about someone who might present with H. pylori and you're thinking of your surgical notes about what a ruptured, you know what I mean, or an ulcerated, what that looks like from a GI bleed in the duodenal artery and all of those things, right? And you're connecting with surgery. And then you're thinking from a medical standpoint, like, does this person have H. pylori? Like, what is triple therapy for H. pylori? What is the mechanism of action of clarithromycin and triple therapy for H. pylori? The more you can do that and ping pong yourself from different topics, which is probably a lot of what Moses does with students. It's what I do. Like, hey, we're doing this right now, but what's this like slightly tangentially related thing? Like, how do we bring that into the equation? And like, how do you make all of that fit in your mind? It starts with your study habits. I was the person in step 1 who had my Pathoma textbook, but then watched Sketchy Path instead of watching Pathoma because I was like, I'm not going to be redundant here, right? I'm going to add Sketchy Path notes to Pathoma. So however you want to do things, I know that's not like the hardcore recommendation, but you should have tons and tons of flexibility to be really liberal with how you choose things. I am not an Anki user, right? Moses, I think you are. I think on Twitter you talk about Anki sometimes, right? I'm not one. I'm happy to talk to students about it. Wasn't my way of succeeding. So be confident that you are a smart, engaged medical student along your journey and you know how to put knowledge into your brain. It does not have to come from someone else telling you how to do that. We're happy to help.
I love it. I won't hold your Anki hatred against you.
I didn't say hatred. I just don't.
Oh, sorry. No, that was beautifully said. And one of the resources that we didn't highlight on the last screen was, how do you know how you're doing? And this can be really anxiety provoking. You know, these tests can be high stakes. You want to know that what you're doing is working. And there's sort of a long answer and a short answer. And the short answer is there are decent tools to track your progress, but no tool is perfect. And the slightly longer version is that, similar to what one can do with step 1, you can take practice assessments, some of which you can see on the screen, and you can gauge how you're doing. And these serve sort of 2 functions. One is to give you a rough sense of your final score and how you're proceeding towards that goal, if you've set a particular target for yourself aspirationally. And then the second reason to take one of these exams is, under conditions that are closest to what you might see on test day, are there content areas or styles of questions that really trip you up? So it can be sort of a diagnostic stress test to figure out, oh my goodness, I'm really suffering when it comes to complex endocrinological sort of feedback loops and how that ties into my pharmacologic management of patients. Now, you know, that's sort of very nitty gritty, but you can zoom out and say, like, even whole subjects, maybe endocrine or psychiatry or surgery. Some of this you might get clues from other sources. You know, if you're reading and you're realizing, wow, a lot of these words, like, they're not coming to the front of my mind as quickly as as other topics, that might be a clue that that's an area to work on, or UWorld if these are questions in the breakdown there. But sometimes seeing it in the form of an assessment that's taken under timed sort of conditions and most closely approximating the test can be really useful. Now, the question, big, bold, and green in the middle of the screen, is when do I incorporate these? And, similar to step one, I am sort of a fan of starting early and doing one every week or a couple of weeks to track how things are going. Is this, evidence-based by some study that shows that that strategy is superior to sort of front-loading or back-loading it? Not at all. I think keeping sort of myself accountable and keeping students accountable and on schedule in that way has been useful for some of the folks that I've worked with. But I'm curious, Michael, sort of what your approach has been in recommending when to incorporate assessments of progress.
Yeah. I also think that it kind of plays into sort of like goals of care, like when your individual goals, right? So there are a lot of people who are like, I want to take one really early because I want to know where I'm at and I want to know like how much work I have to do to get to where I want to go, or I want to feel reassured, right? So I tend to be the type of person who wants to take it like a little bit closer to the exam. And there are some people who want to take it really early and set a baseline. So first, like eliciting, like, what is the purpose of why I'm trying to do this? Like, is this going to be motivating to me or is this going to be harmful to me? Sometimes it's harder to admit out loud, but you're also, I think most students know which camp they fall in. My typical recommendation in terms of shelf exams, right, because often people are in a super time constricted. I think it's a little harder to be like, yeah, I got to, an X score this week and then a this score this week. I think when you talk about things in terms of standard deviation, it's hard to tell me that you actually marginally improved or did not improve, right? If your score goes down like a point or two, did it actually, or did you just like fall in the normal standard deviation of the test? So I would say for shelf exams, right, I would typically wait closer to the test date, right? You've benefited from having more hours on the service. You've benefited from more hours, right, preparing. Maybe like a week out, you give yourself like that extra little motivation to like study when you get home from work, probably at the end of a long week on, delivering. Labor and delivery were super long hours for me. Versus for step two, I think after doing a whole year of shelves and clerkships, unlike step one, I probably would not recommend to someone to take a practice test the first week of their dedicated period, right? For step two, I would say, go ahead and knock one out, right? As soon as you want, right? Maybe you're like, yeah, to Moses' point, like I took psych early, I need to read some psych drugs. Don't wait too long, right? This is not like, hey, I have a 4-week period for step two. Step one, I waited until about halfway. I would do it on the earlier side. You've been studying for this test the whole year. You've just been convincing yourself that you haven't been. Do it early and then go from there. So Moses, you thumbs up to me, which makes me think I said something good.
I love it. Take it
All
away,
right.
friend.
Okay. So I am going to just kind of go through this question. I'll ask y'all to help me out because I see something that looks like histology and, that's going to really drive me away from this question. So, all right, I have, Moses had mentioned that like framing the question and using the last line first, kind of the question first. I have a slight adaptation for that. I like to read the first line, figure out how old they are, how acute the presentation is, and generally what the concern of the patient is, and then the last line, and then I can read the rest of the thing for details. So I have a 41-year-old guy who's coming to the emergency department for malaise. Great, so I'm thinking about someone who's middle-aged. I'm thinking about malaise, which it's not a useful exercise for me to run through a differential diagnosis of malaise right now because it's so broad. Which of the following is the most predisposing factor for this patient's condition? Awesome. So I actually have to make a diagnosis, and then I think in a second order fashion, have to talk to the predisposing factor to this patient's condition. So then I'm going to read the vignette, right? I think it feels like that's a little bit wasteful in terms of time. That helps me from having to read over and over again to find clues, because now I really just need to know that I'm reading this question to diagnose this guy, and then I have to just know a fact about that disease. So he's malaise, he's swelling in his face, hands, and scrotum, and has uncharacteristically foamy urine. All right, so in my mind, right, I actually already have a bucket of a diagnosis for this person. So not reading forward, not being too specific, right? In general, what disease does this guy have? I heard foamy urine, like that really sent me in one direction. And he's swollen, he's puffy, right? So great. I'm seeing lots of people chatting back to me nephrotic syndrome, which is awesome. I would have been super happy if someone just said like edema, just anasarca. Like this guy just has generalized edema, which automatically narrows my differential for malaise to a couple conditions that I think can cause widespread swelling. But then they tell me that he's peeing foamy, which is such a great buzzword for me to be worried about this guy having proteinuria. And of multiple causes for proteinuria, nephrotic syndrome being the one I think that really jumps to mind, right? So he has unknown past medical history. All right, so I'm not going to get great risk factors here, but it's also telling me it's not the absence of past medical history. It's just, I don't know what it is. He denies tobacco use, right? So I'd be thinking like in my mind, like, do I have something that becomes less likely in terms of like tobacco use? I don't know, right? So Moses and I were talking earlier, like what raises or lowers calculus here? I might start to think like I'm making a premature diagnosis of nephrotic syndrome in this guy based on foamy urine. Most common causes of nephrotic syndrome in adults are, there's two kind of big ones that I would think of. If people don't mind in the chat, I know we're doing glomerulonephritis on at nighttime is just not fair. So I'm seeing FSGS, and I'm seeing membranous nephropathy. That's awesome, right? So those are causes of primary nephrotic syndrome, right? So something that has primarily damaged the kidneys, causing proteinuria. Then there are things that people are putting in the chat like diabetes, right? Or lupus or autoimmune disease that secondarily cause nephrotic syndrome. They damage the kidneys in their own way. And then as a result of that, I start spilling protein into my urine. So great. That doesn't help me right now, but I can read the rest of the vignette for clues that make FSGS, membranous nephropathy, primary versus secondary nephrotic syndromes more or less likely. So I don't know that tobacco use helps me right now, so I'm going to keep my hands even, right? He drinks 2 to 3 beers on the weekend. I don't have alcohol use. I also don't think that this person meets criteria for an alcohol use disorder, helping me with either of those. If they told me he drank 4 to 5 beers per day, I might actually elevate the cause of his anasarca being something more like cirrhosis, right? So hypoalbuminemia from a different cause. He is currently homeless, right? And as some people have pointed out in the chat already, board tests have not been very, let's say, good about perpetuating healthcare inequality in their questions. So him experiencing homelessness is going to be a risk factor for him having an underlying condition, absolutely, as it's true in the real world. But I do encourage people, right, when they practice clinical medicine to not only assume that these conditions happen to people who are unhoused or that people who are unhoused have some rare condition that these boards, so personal anecdote there, right? But I agree with you. Him being unhoused is going to be a risk factor for a condition. I don't know what it is yet. 24-hour urine collection reveals 4 grams of protein per day. That confirms my diagnosis in my mind of nephrotic syndrome because I remember from a textbook that it's 3.5 grams per day, right, Moses? Yeah. See, sometimes you don't have to know all the stuff. Renal biopsies performed and they show me the results. Which of the following is a predisposing factor? Okay, this is a question where I'm like, oh my God, I don't know what the renal biopsy is. I'm terrified. Can I answer it without using the image, right? Because I think that that's a good habit. Sometimes we get really scared by the image and it causes us to make choices that we wouldn't make without it. When you get to the point where you're like, yes, I need this, that is when I would use it. So I would look at the questions and I would say captopril use, right? I don't know any association of ACE inhibitors with causing a nephrotic syndrome, right? Maybe I don't know enough about ACE inhibitors, right? I tend to think about ACE inhibitors, right? In someone with like bilateral renal artery stenosis causing some kidney injury, right? That's kind of my association. I tend to think about ACE inhibitors being relatively renal protective. Hep B and Hep C, I kind of have those in my mind as being a risk factor for either like membranoproliferative glomerulonephritis or like membranous nephropathy, maybe FSGS, I don't remember that list. HIV, I remember absolutely as a risk factor of its own for renal injury, right? So that's its own topic, but it also is a risk factor for FSGS, which is one of my 1 buckets. Hypertensive emergency, tends to cause arteriolar damage, right? I wouldn't see a renal biopsy like this. I wouldn't see a nice, fluffy, beautiful glomerulus. They would show me the artery itself, and they would show me onion skinning. So the picture here doesn't make sense for what they would want me to do with hypertensive emergency. I also, I don't know, just nephrotic syndrome without hematuria or anything like that. I don't know. Maybe. Acute renal failure, yes. Nephrotic syndrome alone from hypertensive emergency, I'm not buying it. Poorly treated diabetes, right? People brought it up. It's like one of the most common causes. And I think in the developed world of nephrotic syndrome, absolutely. So then I'm looking back at all the evidence that I was given in the question. And do I have great evidence this guy has uncontrolled diabetes? This is like a yes or no in the chat. Have they given me this wonderful story that this person has untreated diabetes? No, right? I think epidemiologically, if you just told me a person showed up with nephrotic syndrome in the US, I might be like, yep, untreated diabetes, absolutely. But like we mentioned, they've given me this like extra little like piece of information that he's unhoused. So that puts some things in my mind that it shouldn't because of bias, but it does because of being a test taker, like drug use, chronic infections, things of the like. The next thing that I would do is I'd be like, okay, crap, I'm in this position where I actually have to use the image. And I'd be looking at this and I'd be like, I remember from step one, like diabetes causes like that big pink thing in the middle of the glomerulus, and I don't see that, right? So the Kimmelstein-Wilson nodule, yeah, I don't see that in this renal biopsy, so I feel good about eliminating that answer choice. I've already said E doesn't make sense. A, I don't have a great reason. I'm between B, C, and D. If I'm a test take guess person, I might be like B and C are both chronic infections of like a particular flavor. I know Hep C does like cryoglobulin stuff to the kidney. Hep B is the membranous one that I was thinking about. And then I would look at this picture and I would be like, yeah, it looks like I have some scar in some places. And that to me like seems more FSGS, right? So I'm hoping that all of you see that I don't feel amazing about this question, right? So as someone who tutors for this exam, I'm not sitting here being like, yep, FSGS, easy, right? Secondary to HIV, question over, right? I'm actually really having to work pretty hard through my differential here. I'm having to systematically eliminate things. I'm having to leverage pretty vague pieces of information. Like the only clue I've really gotten here is that this gentleman is unhoused and that he has nephrotic syndrome. So kind of a vague differential. Yeah, how do we do that and manage the time, right? Good question. So I'm going through it probably a little more slowly than I would on my own, right? So I would be looking at this and I would, in my mind, cross out captopril, I'd cross out hypertensive emergency, I'd cross out poorly treated diabetes. And then I would really probably labor on the rest of them. But I do think that HIV is the best answer. Moses, anything to add? And someone was asking if you can point on the screen out like how you're looking at this renal biopsy.
Yeah, absolutely. You know, I just couldn't keep a smile off my face because that was just such a masterful example of how to work through a vignette like this. And I don't have that much more to add. I would just offer a few tips and then we can talk about the renal biopsy. So one, I sometimes have students who are paralyzed by the image. So they look at the image and it's just like, oh no, I don't know what's going on. And then sort of the cognitive system starts shutting down. I would encourage all of you to use the image just like you would use any other piece of data in the vignette. Remember how we were talking about some things raise the possibility of a particular diagnosis or lower it? The image is just like that. It's a piece of data just like the symptomatology that the patients are reporting to you, just like the laboratory and imaging workup that you get. If you don't immediately know what the image is, that's okay. You can use the other information in the vignette to guide your interpretation of that image. And I promise you that this is what like board certified pathologists do. That's why they ask for the clinical history before they look at the images. That's why we have these really cool clinical pathological conferences where you have, you know, the disease expert and you have the pathologist and you have the radiologist, and they're all talking about what's going on in these vignettes, because it's very difficult just, you know, if someone woke me up in the middle of the night and showed me a renal biopsy image, well, one, that'd be very cruel, but two, like, I'm not sure I would be able to make much of it. And so that's big picture, just a tip I would leave you all with. In terms of this actual image, first I would say, like, first recognizing this is a kidney, right? Like, this is an image of a kidney. And some of you in the chat looked at this and it went off like that. Like, okay, perfect, there's a kidney biopsy. Some of you maybe not, and that's totally fine. Going back to the edema, you know, big picture, edema comes because you have problems in your kidney and your heart or in your liver, right? And if I had to choose one of those three organs, this looks more like the kidney to me than liver. I would expect sort of sinusoids and a slightly different pathology. If it was the heart, I would be expecting sort of myocytes and that striated appearance. I'm not seeing that. So even if I know nothing about the vignette, I'm looking at this and just knowing edema, I'm like, okay, I'm probably in the kidney. Secondly, just thinking about what lives in the kidney. And Michael did a beautiful job of talking about the vasculature when discussing the hypertensive emergency. But remember that you have the glomerulus, you have the tubular structures, you have the surrounding vessels, and then you have the parenchyma around that's supporting all of this. And so smack dab in the middle here, we have a glomerulus. Over here, you can sort of see some tubular structures. And then if we focus in on the glomerulus, you see that it's not really that symmetric. There's areas over here where you can sort of see finer details, maybe like some of that tuft-like description that you often see. But then over on this side, you see a lot of pink, and pink often is sort of scar tissue, like Michael was saying. You see this scar tissue. And unfortunately, we only have one glomerulus in this picture, but often you can compare glomeruli and see, is this a process that it's affecting every glomerulus sort of equally and symmetrically? Or is this something that's sort of, you know, haphazardly picking off glomeruli here and there? And so the name itself, focal segmental glomerulosclerosis, which is what this ends up being, and Michael, excellent job for picking up HIV as a risk factor for that. The name tells you everything: focally and segmentally scarred, and that's what we see in the image. Anything to add, Michael, that I missed on the image, or any other tips?
No, I think, yeah, I probably tried, I maybe didn't like teach as much as I could because I was trying to like just describe uncertainty. Hep B and Hep C are both risk factors for membranous nephropathy. And then as Moses pointed out on the biopsy, right, you are seeing focal changes, right, versus membranous nephropathy, which you would expect kind of to be more diffuse, right? So the mesangial thickening and things like that. You're seeing like weird discrete areas. So if we went back to our original primary versus secondary, I'm thinking this is a primary renal injury. Epidemiologically, I know it has to be FSGS or membranoproliferative or membranous nephropathy. With that alone, looking at the picture, I'm like, this looks like a focal thing. This doesn't look like a diffuse thing. I think that would be plenty, right? It's not elegant, but it gets us where we need to go. Then I just have to be like focal risk factor HIV, right? So the list, I think, unfortunately, right? So HIV, heroin use, and right, non-white race are typically listed as risk factors for FSGS. And then membranous nephropathy tends to be chronic infections, like more common in Eastern European. So
Beautiful.
absolutely, right?
I'll throw in sickle cell as well as another thing that sometimes is affiliated. I mean, that was just so beautifully done. Honestly, guys, we should just go home because I don't think I can live up to that performance with this one. But I will start off by just acknowledging the emotion that probably comes over me and everyone when you see this, and that is, my goodness, what a block of text, right? We don't have the benefit of a nice image to help us here. But I remember being somewhat intimidated when I saw this block of text. I'm like, I'm supposed to interpret all of this? And the key step for me was just to stop, take a deep breath, and have a systematic approach. And so for me, I'm reading that last sentence and I'm seeing what is the most appropriate next step in management of this patient's condition. And the first thought that comes to mind for me is, what is this patient's condition? Which then leads me so naturally to then, well, I'm going to find out as I read this vignette. So that's the first step for me, is like, you diagnose before you treat, except in cases where you have emergencies or, you know, empiric treatments as you figure stuff out. So, you know, general statement. So here we have a 56-year-old Black male comes to the clinic complaining of cough and trouble sleeping over the past 6 weeks. And because I love clinical reasoning, I would sort of reframe this as a middle-aged African-American gentleman coming in with, I would say, subacute to chronic trouble sleeping and cough, right? And just like in the last vignette, don't get caught up in that first sentence and be like, oh my goodness, what are the 10 billion different causes of cough? Or, I mean, I have trouble sleeping last night. Like, you know, the differential is incredibly, incredibly broad. Keep moving forward. And I like to think of it as like chaining reasoning. So the first sentence puts me in, you know, the state. The second sentence puts me in the county. The third, and you just keep zooming in, and you just want to make sure that every subsequent sentence is being interpreted in the context of the previous sentence. Okay, perfect. So he reports that his exercise tolerance has decreased recently. So again, when I think of shortness of breath, which, you know, I choose that over trouble sleeping just because I'm more comfortable with it, I'm thinking, okay, or cough in this case, I'm thinking, is it heart, is it lung, or is it something else? Because we have the dyspnea pyramid, and those two are the, you know, the base of that pyramid. But I'm not going to dwell on it. I'm going to keep going and try to find clues to the diagnosis. He used to be able to walk 8 blocks from home to his work at the supermarket, but he now becomes short of breath. Again, so this didn't add a whole lot. I already knew that he had exercise tolerance. This is really quantifying it for me, and it's a real deal. I can put a number to it. It says here that he has a cough productive of minimal clear sputum that is worse with exertion and lying down. So at this point, you know, there are diagnoses that are going through my mind, and folks in the chat, just, you can throw out tentative diagnoses, and that's good. There's this sort of cognitive theory that talks about sort of type 1 versus type 2, or fast versus slow thinking. One is very intuitive, and it's not always clear how the mind makes connections between disparate concepts or ideas. And the second is very methodical, it's very organized, and you really want to draw on both without getting bogged down in either. So right now, I'm thinking middle age, exercise intolerance, I'm sort of leaning heart, but there's a cough and sputum, so I'm thinking lung. I'm really asking myself, what am I going to find on exam? What am I going to find in further workup that will tip me one way or the other? And I'm suspicious that there's a heart problem going on. So we hear that he endorses shortness of breath while lying flat at night, which is relieved by sticking an extra pillow under his head. And this is where the light bulbs start going off. I was already suspicious of the heart. This was, you know, the county I'm in. Now I'm zooming in into the neighborhood. And folks in the chat, throw in the diagnosis that you think is most consistent with the clinical picture to date here. And I'll pause just for a moment to see what's going on, going up on the chat. What are we finding, Michael?
It's unanimous.
I love it. So in my mind, this is really making me think of heart failure, right? And the classic cardinal features of heart failure. So he denies chest pain, fever, wheezing. The wheezing is important because, you know, we had a cough. This is a middle-aged person. Could this be COPD? But again, there's a lot of data sort of pointing away from that. Past medical history notable for coronary artery disease, hypertension, type 2 diabetes, a very sort of metabolic picture. And we know that 2/3 of heart failure is ischemic in nature, you know, roughly speaking. And so there are risk factors now. And at this point, I just, you know, want to throw out that it's important to hone in on a diagnosis, but it's also important not to anchor, which is another, you know, cognitive bias. So at this point in the vignette, I'm like, ooh, I really think that this is sort of heart failure related, but I don't want to get stuck on that track without considering subsequent data. So we keep going forward. Medications include metoprolol, atorvastatin, and metformin. This all makes sense. The metoprolol, coronary disease, as well as a statin, given his history of hypertension and type 2 diabetes. The metformin, again, for the type 2 diabetes. We have vitals that include a temperature. He's not febrile. He's not tachycardic, mildly hypertensive, breathing a little bit fast. And on exam, neurological function is intact. And the cardiac auscultation reveals no murmurs or gouts. At this point, I should also say that, you know, if this was a really florid heart failure exacerbation, maybe I would expect to hear a gallop. Does that mean that the absence of that finding completely takes heart failure off of the table? No, and this is one of the subtleties of step two, which is you'll get a lot of signal in for a particular diagnosis, but sometimes one element will be missing or two elements will be missing. And I can say as an intern, this comes up all the time. And so don't let yourself be overly swayed by any one particular exam finding. You really want that gestalt, that sort of big picture.
Yeah, because you're using the word signal, which I love. So how would you use a different word to describe like the fact that this guy's having increased sputum production?
Yeah, so that's another great question. What is my differential for sputum production? Is it infectious in origin? Am I getting a signal that it's green or purulent? Um, am I getting information that would make me think COPD? Are they giving me a time frame for the sputum production? Is it greater than X number of months over X number of years? Over 2 years, which would give me a clue that the test writers are really pushing in that direction. So it's not only the signal, but sort of the way it's framed that can really help you decipher what to make of it. Pulmonary auscultation reveals mild bibasilar inspiratory crackles. So there's some volume on board here. I'm suspicious that it's from the heart, and we keep going. And EKG reveals evidence of left ventricular hypertrophy. Notice that with every sentence, we're adding evidence that the problems in the heart, there's a heart failure sort of situation going on here. And remember that heart failure is a clinical diagnosis. So it goes all the way back to how we started all of this off, where, I don't see a BNP, NT-proBNP right now. Would that really change my assessment of this patient? Probably not. So I'm just trying to make connections with the things that we've talked about so far in the webinar. And then we get an echo that estimates an LVEF of 45%. And so now we arrive back at the question, which, as a tip, I read again just to make sure again in my mind what it is that I'm actually answering. What is the most appropriate next step in the management of this patient's condition? And so I'll take a moment, let's give it 10, 15 seconds, take a look at the answer choices, and in the chat, you all vote, put the letter of the answer that you think is most reasonably the next step in management for this patient. And when you see the answer slowing down, Michael, let me know.
They're slowing down a little bit. I would say, and I can also estimate. Do you want me to give like
Please, yeah, please
a poll everywhere? Based on I have most votes for C, probably second most for B, and a couple for A. Nobody wants to do D or E.
Okay, perfect. So now what I would encourage everyone to do is to have a clear articulation in your mind. Why did I pick that answer choice, right? And you could even give yourself a confidence rating. How confident am I in this particular answer choice? And this is a trick that I use myself, and sometimes I have students do as we're working together, because it's a different scenario if you're 100% sure that it's the right answer and you end up being wrong, versus 100% confident in you're right, versus not confident at all in you're right or wrong, right? You can make like a 2x2 grid. And the way that I would review this question sort of depends a little bit on your answer to that question. Because if it was a total guess, then that changes the way that you approach the review. And it's like, okay, where, was it at sentence 3 or 4 or 5 that I sort of went off the rails in terms of my reasoning and I got very confused, versus, was I answering the wrong question and I was very confident in my right answer because I was actually answering the wrong question. These are some of the questions that you can ask yourself. So when I think through this, first, I'm very clear about what I think is happening. I think this person has heart failure, which is a clinical diagnosis. I think that they're already on one medication that has proven mortality benefit, which is the beta blocker, metoprolol. And then I think to myself, okay, is there an emergency going on? Look at the answer choices. What am I going to pick? And let's just go from top to bottom. So the first answer is cardiac catheterization. And in my mind, I'm thinking, okay, do I think that this person has an acute coronary artery blockage that requires reperfusion essentially emergently to save their myocardium from necrosis and dying from lack of blood flow? And I'm not seeing chest pain, and I'm not seeing EKG changes that are consistent with a STEMI that would lead me to pick A as the right answer. So now I would encourage you, if you thought that A was the right answer, first of all, that's not a big deal. But what parts of the vignette pushed you towards A? And conversely, sort of, I would encourage you to think about my reasoning in terms of not seeing chest pain and not seeing EKG findings. How did you interpret those two negative into your assessment of why A ended up being the right answer? Second is initiation of treatment with nitroglycerin. And what I'm thinking here is I'm thinking, okay, I've seen nitroglycerin used for chest pain, which the patient doesn't have. On the other hand, there was a trial that showed a mortality benefit with isosorbide dinitrate in combination with hydralazine, but that's not quite what B is. So B is tricking me almost because it has words that sound similar, but it's not quite right. And my teaching point for this is that if you get that gut sense in your stomach that you're like, oh, this sounds sort of similar, but there's something sort of off about it, I would sort of try to listen to that and then try to articulate in more concrete terms why it is that it doesn't sound quite that right. So that's what I tried to do for you all. There are elements of this that sort of sound like something that's related to heart failure, but not quite. So I'm ruling that out. Initiate treatment with enalapril. So first, recognizing that enalapril is an ACE inhibitor. Secondly, remembering that ACE inhibitors have a mortality benefit in heart failure. And then the third step is there anything in the vignette that makes this a good idea in terms of comorbidities? And or am I seeing something that would be a contraindication? So for instance, if the vignette subsequently said, oh, and the patient has a history of, angioedema and airway compromise, then maybe I wouldn't pick this. And if an ARB or some other medication with mortality benefit was on the list, like maybe spironolactone, I would pick that instead. That would be a rationale for picking one mortality benefit agent over another. But again, I'm not seeing contraindications to it, and I'm seeing that this patient is, has room to come down on the blood pressure, which would have benefits for their health more broadly. And so C is the top contender for me. And then I'll quickly go through DME because not many folks seem to have picked that, but atorvastatin's a statin. Common side effects for statins are myopathy. I'm not hearing a story about that. I think the patient has a very sort of metabolic syndrome picture, and I think a statin is appropriate. And then lastly, the patient is symptomatic, has heart failure. There's room for more goal-directed medical therapy here, and is hypertensive. So I do think that their treatments can be optimized. And so in light of that chain of reasoning, I would go with C, initiating treatment with enalapril. And I will stop there and ask, Michael, do you have any extra pearls, extra sort of reasoning tips for the folks on the webinar?
Totally. Yeah, I think that you highlighted all of the most important things, like moving through the vignette. What tilted me right with this person with risk factors for having an acute COPD exacerbation versus an acute heart failure exacerbation. I think the one thing that I would also say is a helpful exercise, right? Whether you see a patient and you're like, hey, in real life, what would have been another way this patient could have presented with this disease, right? Additionally, how could this question have been written that would have made A correct, right? So which of the following steps in management would prove this patient's volume overload, right? So getting a cardiac catheterization, looking at the pressure in the, the right atrial pressure and everything like that would potentially give you helpful information to the fact that they have, right? The echo kind of does that for you, but cardiac catheterization, like Moses said, not at all necessary. The next point that I want to make comes up from a answer choice that came through the chat, which is a great answer. and does a good job of highlighting like sort of how our minds can betray us when we take questions, but help us so much to be a good doctor. And that is like, oh, well, he has diabetes. Like, what if he had a silent MI and the silent MI is what's provoking his heart failure exacerbation, right? And you can convince yourself of this like beautiful narrative and you're like, yes, I'm finally getting the question correct that UWorld is going to trick everyone else with. I would encourage you to look at every question you take and be like, this question was written for most people to get correct, right? This question was not written for 1 to 5% of students taking it to get correct. And additionally, if you feel like you're having to invent large steps between things when information is not given to you, right? So they're not going to tell you that the EKG shows left ventricular hypertrophy and not tell you that he has huge Q waves, right? That he had an infarct 6 weeks ago when this all started. Or that he doesn't have, you know what I mean, T-wave inversions or any of those things that would make you worried about an acute ischemic picture. So be careful where your mind can travel, right? I tend to use the phrasing with students. I look at every question in the vignette once I have a pretty good diagnosis in my mind. And I think I arrived at it right when Moses did, which is when he described orthopnea, right? That he has, I was like, okay, great. I have this diagnosis in my mind of a heart failure exacerbation. Every sentence for the rest of the vignette I looked, I said, does this prove my point? Does this disprove my point? Or is it something that I need to like put in my pocket for later because I don't know what it means, right? Denying chest pain, it doesn't mean, you know what I mean? It doesn't disprove me. So I only make huge changes to my overall impression if I find things that disprove me actively. That helps me from not letting my mind wander because I do exactly what some of the people in the chat did, which is create these beautiful narratives. Prove yourself wrong, right? That has to be your logic. I need to prove myself that this is not just a simple heart failure question, and I don't have any evidence in the question that does that.
I could not have said that any better. Honestly, that was perfect because I do that all the time too. We sort of build stories in our head and then sort of force answer choices to become. We sort of write our own questions and then
Yeah.
make the question the answer that we want to be correct the correct answer for that question. But then in a way you're answering a phantom question, not the question that's actually in front of you. So that's a really beautiful point. I don't know if you had that much more to say, Michael, but
No,
otherwise.
you like covered everything about heart failure, right? And I think, yeah, absolutely, right? So, great. We're going to talk about MST a little bit. I think that hopefully you saw how much Moses and I love doing this, and that 2 questions, like I think we probably each could teach one of those questions for way longer, right? We could have been like, great, beta blockers, heart failure. What are the 3 beta blockers that improve mortality and heart failure based on this? And like, what are the side effects of beta blocker therapy and all of these things? We can spiral and it's awesome because we love it. And I think that's Moses and I met for the first time right through this. It's our shared common ground as people who work for MST, like our underlying nerdiness, I think is what helps us like connect to our love of medicine and want to share that with people. I think our kind of edge is that we tend to customize it and have gone through the exams ourselves and want to sit with you and be really thoughtful, both in the way that we approach the patient and the question, but also your schedule, right? So how can we help align ourselves with you as tutors, navigate what is sometimes a very stressful testing situation, just like illness can be stressful for people, and get you to where you want to be in that journey. So how a tutoring session looks for one student is markedly different than how it looks for another. Sometimes it's just, hey, I want to go through some questions. I want to do this. Sometimes it's, hey, I'm really struggling to form differentials for large buckets of diseases. And how can we do that? I have students who would say, hey, I'm just really struggling to figure out this mechanism. And I'm like, great, I have the bandwidth to dork out on that. Like, I'm going to go tell you why we can use like methylene, I don't know, why amyl nitrate can cause serotonin syndrome. Great, I'll get back to you on that. Like, I love that. So you really just kind of form a partnership, right? I think what we strive for in a patient-physician relationship, like with someone who, you know what I mean, tutors through MST, to really just kind of walk through taking tests with you, offer advice, be a sounding board, and hopefully share like amazing medical content and strategies for getting through questions that make us scratch our heads. Moses?
Yeah, I can't emphasize how much the sort of the personalized nature of this can be very helpful. And then, you know, I think the residency program I'm in would like to make people think that the phrase "never worry alone" is sort of a patented thing, but truly it's something that applies both to med schools and residencies that value students and their well-being, but it's also true of MST. I think we're here so that you don't have to worry alone. And just by looking at how many chat comments there have been over just the last hour and change, we recognize that there's a lot of questions. If we don't get to everything, it's because some of these things are very personalized, and we could go on like this forever. We encourage you to please contact us. We love talking about this stuff. And I hope that really came through in how much we sort of nerd out over these things. And we're really here for you. With everything going on, it's nice to know that there's a community of students and future colleagues working together to be the best physicians and clinicians that we can be. With that, I may stop sharing the screen. We might just have a few moments. We've sort of already gone over a little bit, but I'm trying to look through if there's anything that we haven't covered.
I've been doing my best to keep up with the chat, and I think that hopefully I've either answered directly or said it out loud in a segue. There was one clinical question that maybe popped up that I don't know that we expressly, but I think Moses did for the indication for him being put on an enalapril, so an ACE inhibitor, having mortality benefit in someone with heart failure with reduced ejection fraction. Yeah, so there's the question from headquarters, right? So that we had gotten in advance of, which is how do you tackle subsections of clerkships, and how do you study for that, right? So I'm on peds, but I'm going to be going to peds GI clinic this week. How do I do that? Again, my way of doing it is I'm just so UWorld centric, right? So go to peds, right? Then go to the topics that you could be tested on in peds and just click GI, and there might be 25 questions. Make a nice little common GI presentations in peds, and then you're never going to be penalized for knowing more about something than you need to, right? So there's no UWorld question on abdominal migraine, right? But you go to peds clinic and you see the diagnosis of abdominal migraine several times. Why don't I go read a little bit at that when I get home? It's going to be more helpful for you long-term, I think, to have a broader bucket of things, because then you know details that help you separate.
I love that. Really focusing in on the key resources. And I would just add, from an internal medicine standpoint, what's tough is it's so broad, and that's why it's 75, combined with a few other things, so much of 75% of the exam. I personally found that taking it sort of piece by piece and then making those connections. Michael already mentioned the blog post that talks about how to stay connected with previous questions that you've done. And I would go read that blog post, and I would also think, if you're a flashcard person, like I was, making flashcards judiciously, because sometimes you can go overboard and then it starts taking over your life. But that's another way that I stayed connected to topics.
Absolutely.
Yeah.
Cool.
Well, folks, I think we've answered most of the questions. It's been a blast spending the last hour and a bit with you all. And really, I just want to end by thank you all for joining us. I know time is precious, and wishing you the best of luck with any of these exams that are coming up. There is a whole world after the exam is over. And it's sometimes good to remember that this is just one step along your journey. You all are incredible human beings that have decided to do something really noble. And I can't wait to consult you all as you become professionals, because I will have many questions. So from me, really, best of luck. And you got this.
Echoed. Retweet.
All right. Bye, everyone.